Good morning. It's there we go. It's 10 o'clock on July 25th, 2022. Convening the Prescription Drug Affordability Board. And before I do that, I want to ensure we have a quorum. So at this point in time, if you'd introduce yourselves to ensure that we have a quorum.
Jim Murphy, House Rep from Grafton 12.
Bob Woodward, newly appointed academic, I guess.
Yes.
No legislative. Right.
Todd Payton. I was previously with AARP. I've since left that, so I was the governor's appointee, and I'm still here.
We have 3 members of the board, and that constitutes a quorum. As far as the agenda review, is there anything on the agenda that people would like to change or move? There's one I would like to do, but it's something else anyone else would like to make a change on. I'd like to move, with the permission of the board members, the assessment, the prescription drug usage reports with Andrew and Mary Fields from down, I think, 4th on the agenda up to number 1, so they have the ability to give us their overview and move on to the daily lives. Or anything else people like to move or add to the agenda? No. Moving on, is there any concerns with the, before I move on to it, first, we have a new member. I'm very excited. A colleague of mine, Representative Dr. Salloway, brought to my attention a gentleman who would be very useful to the board. And after reviewing his resume and your CV, sir, you're more than justified in being on the board. If you want to give us a couple of quick minutes, I know you come from extensive background in the pharmacoeconomics of what's going on within pharmaceuticals. You've been at the University of Washington University, also recently retired, I believe, from the University of Hampshire, which is a as well. So if you want to give us a little background on yourself.
Sure. Thank you very much. It's a pleasure to be here. I appreciate being invited. Yeah, I'm going to go bippity boop through a variety of things. I don't want to reveal everything about myself. I want to stay a little bit unknown. Haverford, where I was computer geek for a bachelor's, Peace Corps in Venezuela, Washington University in St. Louis for a PhD in econometrics, the University of Western Ontario as an assistant professor in economics, during which I served with Stuart Altman in what was then HEW in Washington, the assistant secretary for planning and evaluation. Moved to Washington, went back to Washington University in '78. Part of the efforts there was to start up a pharmacoeconomic transplant research group, which ultimately was arguing that Medicare was losing money by not covering the immunosuppression medications of transplant recipients, and we convinced them to go from 1 to 3 years coverage, and then from 3 to 5 years coverage, and then from 5 to lifetime coverage, even for people covered by Medicare, not because they were 65, but just because of their end-stage renal disease. Came to University of New Hampshire in 2001, where I've been teaching not just finance healthcare, but the economics of healthcare issues also. Here I have contributed to a report on the value of limiting arsenic in municipal water supplies, which contributed to legislation that reduced those limits. Have been interested a little bit in the PFAS issues, but it's harder to get a handle. There's so many PFAS. I'm totally supportive of the legislative actions that New Hampshire has made to limit the PFAS, but that's of very few. I think it was 4 or 5 compounds as opposed to the 15,000 that are out there. that are kind of scary. I have two kind of lines. One's cost effectiveness, value of information. I'm a long fan of spending too much money on collecting information that doesn't get used. I've actually done that, turned that analytic engine on myself and done a cost effectiveness analysis. And argued it could be at least cost effective in some situations, not necessarily in all. And I'm very pleased to be able to join you here and hope I can contribute add constructive suggestions to the board's efforts. Thank you.
Thank you for that. And appreciate you being on the board with that background. I'm sure we'll find a use for it. Definitely. In regards to the next one on the agenda after this would be looking at the May 23 minutes. If there's any concerns with the minutes, I know Attorney Fahey that you weren't here. I noticed again noted that you're submitting to them as recording secretary. You probably will recuse yourself
I
from
will,
voting on
I'll
it.
abstain.
Was there any questions on the revisions on the minutes? Seeing none, then I'll make a motion of somebody to approve the minutes.
Always
I'll
ask.
move it.
All right. Let's have a second, please.
Yes,
All right. So moved by Senator Rosenwell, seconded by Representative Marsh. And we have two that are abstaining, Representative Murphy and Attorney Fahey. All those in favor say aye.
hi.
Anybody opposed? The ayes have it, minutes moved. Okay, in regards to the, it's Andrew, there he is. You want to give us an update on the spreadsheet that you put together yourself and also, I believe, Ms. Fields. In your packet, you'll see some of the numbers that he and she was able to put together based upon our last conversation. So would you like to go through that spreadsheet and give us an update on what you folks did?
Sure, and I actually have Emily Caccini and Mary's still out. So I'll share my screen here. Works. So one of the, we talked about a lot of things obviously last time, and we don't have sort of information to cover all of those things, although I want to focus on one part of this right now and then give you a little preview of coming attractions. One big thing we talked about was how challenging it was to look at individual drugs and how, ultimately as the drugs come in and out and everything, it would be hard to keep track of things in terms of trends. So we mentioned that there are a few systems out there that group drugs into therapeutic classes, and this therapeutic class grouping is really for analytics, cost monitoring, that kind of thing. A lot of different drugs could end up within one therapeutic class, but they've been proven useful over time as a tool to monitor what's going on. So something a PBM would be using for sure. And you can see on the screen how they get grouped into ways that also are a little bit more understandable to a layperson. They often have the condition being treated kind of implicit in the class definition. So Mary, Emily, do you have anything else to add about that, or kind of an example you could give?
Sure. So just to give a couple of examples, so things like under the commercial for the first drug therapeutic class for the anti-inflammatories, it would be drugs such as like Humira and Enbrel. So it's going to roll everything up based on how the manufacturer has submitted to the drug reference holder. And in in this case, it's Metaspan, just for reference, or things like, the thyroid agents. It's going to include not only your brands like your Synthroid, it's also going to roll up all of the generics as well.
So it takes the NDC code.
Mhm.
Basically, one NDC can be in only one class. So
Correct.
there's some decision making about a drug that could be used for multiple things, and they're putting it into the primary class of use. So, this is the way I think we want to go forward with looking at sort of cost trends and sort of digging into, what may be the drivers for things. And what we can do, though, is if we see, like if we're looking at this next year or this year and we see a drug class that has, increased, then we can do the next level down and look at the specific drugs to see which drugs are driving that increase. So it could be a new drug, a new expensive drug that is driving an increase. And it could just be obviously just one single drug. Or it could be we look deeper and we see it's across the board increases. So what we included in the packet focuses on patient costs only. And, so we dropped Medicaid from this just to make it a little simpler to look at. So what this has in it is the patient paid amount for the time period for that year, fiscal year 21, the total for that class. So, it, again, rolling up everything into the class. Then we have how many patients, unique patients, used the drug, a drug within that class during the year, or multiple drugs within the class that year. So, and then how much, so then just taking a little average and showing the average that patients paid per patient. So if you think about that as like a human being outlaying a certain amount for that class of drug. So that's certainly, one way to look at it. And then we show the increases down below. This is not comparing, unfortunately, the per patient cost. That's really what it should be doing. It's just sort of comparing the overall costs. So that's what we put in the packet. And sort of after this got in the packet, we after a conversation we had with a representative merchant, we did a little bit of kind of further work to kind of help feel you all out on where you might want to go next. And so I'm going to share quickly another screen, which has some work Emily did. So you'll see this is a lot more columns, and I just want to quickly go over this. So maybe, we can treat this in more depth the next time. We can send this out ahead of time, much more, to give you a chance to review it. But here what we do is we, again, just focus on the patient paid amount. So these, first two columns are very similar. And then we get at days supply, which is something we've talked about, because, a 90-day prescription may be cheaper for a patient per days of supply than a 30-day. We give, and then we give rates of things. So this is going to be really key for comparing year to year because the population's changing, the diseases are changing, the drugs available are changing. So looking at rates will make it a lot easier for us. So just, I wanted to highlight kind of the most kind of granular way of looking at this, which is how much is the patient paying per day of supply on average, right? So for a particular drug class, in this case, analgesics, anti-inflammatories, on average, when that commercial copay happens, it's, and this is 2020, $1.46. So per day of supply. So if they're getting a 30-day, it'd be 30 times 1.46, 90-day would be 1.1 times 1.46. So it's kind of lumping it all together. And then over here, we can see how in 2021, it's gone up to 1.97 per day supply, which is a big increase, obviously, and of, let's see, I think it's 37%. So in 1 year, the per day supply increased by 35% across all these patients. And we're talking about, tens of thousands of patients. So it's a massive increase. So that would be something, as we're, maybe right now we'd want to look and see, well, what was driving that? Which drug is the reason why? But certainly, going out into the future. So when we have a chance to go over and talk about this in more detail at the next meeting, we'll want to kind of really figure out what measures do we want to track, and then we can start tracking them. We can track them, we're thinking maybe about tracking them quarterly or twice a year. So that we can define kind of thresholds of increase where we would want to dig further. You'll see there are going to be decreases too. So this next line, next therapeutic class, has a decrease in cost, and that's anti-diabetics. So, obviously as new brand drugs come on, that will cause increases. Generics come on, it'll cause decreases. So, it'll be like, I think this will be a window towards kind of picking up on those larger trends for the board. So I don't know if anyone has any questions about either of the two things I shared.
Andrew, this is Gary. A question for you on the first of all, thank you for putting the numbers together, because there's a lot of work behind this, and I think we're going in the right direction, but that's one opinion of many. But one of the things I noticed here is that when I look at, if you go back to the original slide we have in our packets, please.
Yep.
If I go back and look at Medicare,
Whoops.
second line, anti-diabetics, patient paid per patient is $191. Yet
Right.
when I go to the commercial side, to look at the same thing, it's $301,
Right.
which is a 50% increase over the Medicare rate. It'd be
Yeah, that's-
interesting why that's so much of a delta.
Yeah. I mean, that's exactly the kind of thing, like one payer, and the Medicare, it's, the Part D plans are commercial plans. And so,
Right.
is it the mix of drugs? Is it that for every drug if we were to look and see every drug, and we'd see, why is commercial always, charging the patient more? So yeah, so that's the exact kind of work we can do here.
And the theme that I just mentioned is not isolated to anti-diabetics. If we actually go back and look at some of the other classes collectively, would it be, as we said, what I'm seeing on the data is that the commercial patient population is paying a higher price than the ones on the Medicare. Now, there could be, like you said before, day supply, it could be a mix of products, but it's interesting why that would occur.
Yeah, and that's exactly right. And so that, and I think the data will be able to tell us that. I think commercial plans are obviously a lot more diverse than the Part D plans in terms of their patient share. And so, we may drill down and see literally just that every single or most every single drug costs more to the patient. The other thing I want to say that I haven't mentioned yet is that on the last meeting, we talked about having the commercial really zeroed in on the public purchasers. So state employees, university system employees. We talked about how that's still going to be plenty of data to look at. And so, and we're still working on that. There's some, data irregularities we're kind of trying to track down to make sure we can isolate those groups correctly. So for now, this is just all commercial, but eventually we'll zero in more on the public purchasers or break that out as a subgroup, because presumably we'll want to compare public purchasers to all other commercial, to again see, like, are there important differences there. So that's all I have to share for today. I didn't want to take too much time, but next time we'll have sort of a much more detailed look at how those rates are changing, and maybe we'll take a couple of drug classes, Emily, and drill into the the reasons why a change might be there or a difference to Medicare might be there. And we also, the other thing we want to be able to do is go back a few years so we can see, how it's been trending. Are these increases really are new, or have they been steadily growing over the years? And the increases over year, if we go back far enough or enough years, simply the benefit structure of the commercial plan or the Part D plan, like those will be a big part of it, obviously, because people have to pay a lot more on their insurance generally. There are so many more people with high deductible plans now than there used to be. So those kind of copay increases, maybe, they're a huge factor in this too, just the general things that have been negotiated with the PBMs and the purchasers. So that'll be a kind of twist that we'll have to kind of factor into any trend analysis. There's a lot of moving pieces for sure.
We have a couple of questions, if we could, Representative Murphy.
Thanks. Thanks, Andrew. This data is great. My two questions are that patient paid per patient, is that the out-of-pocket cost? And then is there a column or a way to understand the total cost per day, say, per drug? I mean, if they have rebates or other, copays or other supplementals, I guess it's good to know exactly what they pay out of pocket per patient, but what is the total cost and how do we find that?
That's a terrific question. So we did do what we know in this data. So this data is based on what's recorded in the insurance company or the PBM for their claims. So, we have, what did they pay the pharmacy? And we had what did the pharmacy get? And what did the the expected copay of the patient? And so we have literally no insight through this data about rebates and about any discounts the patients may have paid on their copay. So that is sort of a void in this data. And we do have the total paid amounts for sure, that paid to the pharmacy amounts. And we showed some of that, the prior meeting. So, that's important. I mean, it's an interesting part of this too is, well, should the patient be paying, a set percentage of the total, or are they a fixed copay? My insurance, state employee insurance is really good. Other people are paying 1% or have drugs where they have to pay like, half or something. So all of that will be important to what how affordable it is to the patient. And I think, Representative Marsh has been, every time I speak with him, he's, really how much, where are the profits going? And, we just, with this data, we don't see, or where are the dollars going? We really just don't see enough with it. We don't have a way of calculating what the plan paid the pharmacy, how much did they get back in a rebate? The stuff in this spreadsheet shared for the meeting is what the insurance company is telling us they expected the patient to pay to the pharmacy. They don't ever find out the actual amount. It's their copay based on the benefit plan that the member has.
Attorney Beatty.
Thank you, Mr. Chair. So Andrew, this is but although you can't get granular, you're still seeing system-wide changes, right? So you mentioned rebates and such, but system-wide, the prior screen you had up showing an increase year over year or a decrease year over year, that is, we can see what's happening within the system. And then we got to figure out what components might be moving the system. Is that fair?
Well, so the board is I mean, the board's focused on affordability, and, you know, I think in other states, affordability is really about the patient having to fork out money. You know, and I think, but they're obviously also paying some of their salary in a premium, right? Or, you know, have purchased some insurance. You know, some of that's more regulated or more constrained than others, other times. But, you know, I think it's true that we can see the system-wide changes. It's just, we'll never know about some, unless we have other intelligence about some rebate related swing that's significant, you know. And I know the board has talked about how to figure out how to get some of that information, or how to get the wholesale costs better, the manufacturer information. So, but I think this is still valuable. Absolutely. I think it's the most valuable for the patient, because the patient cost is going to be almost always what the patient is paying. So there's a lot of interesting things. I mean, if in the future we focus on a particular class of drug, or, you know, a handful of specific drugs, you know, we can look at the distribution of how much patients are paying, you know. So we have the issue, obviously, if it's a distribution, so we don't know, you know, how skewed that is, how the mean might be skewed and things. So I think there's a lot that can be done there. I think on the total paid side, it's still valuable. It's still valuable for getting a good idea of, you know, the amount of money changing hands. Tracking it back to what the overall system cost is for a drug, though, that I think is something a lot more challenging.
Well, I guess I'll just speak for myself as a board member, understanding the charge of all of us in this board and me as a member of it. We were supposed to get through, and this is wonderful, so thank you to both of you. But the murkiness of it, we still get stuck in the murkiness, and we can't really figure it out. And the charge of this board, among other things, is to get a handle on what the public payers are paying in New Hampshire. And the reason I ask about the system is that I think we can agree that there's a system-wide situation here, which we can look at. We can see some changes in the system, but then you get more granular. So I know I've asked the question indirectly, and I don't know if I'll ask it today, but I'll just put it out there. I will be asking at some point for you to tell us where your gaps in knowledge are, and how we can get you more information so that we can get to the granularity that we need, should the board decide it needs granularity.
Yeah.
Thank you.
Thank you. Councilor.
Andrew, thank you very much. It's an ocean of data, and I worry about my ability to swim in it, given that I can't see the bottom and I can't see the coast. One of the ways to handle such a large volume of data, I think, is to focus on what it is we really want to get out of this. And it seems to me, for one suggestion to start out with, that one of the board's interests, I think, is a state budget, which would be affected most by the Medicaid column, which I would advocate, at least for the total expenditures. And if you have some by the state, that should be a table in addition to the Medicare and commercial. The second approach is what the patients are paying. And that is, as we've seen here, is suggested to be different from Medicare and commercial. That's not surprising. There are two ways to look at this kind of data. One is to decompose it, that is to drill down and look more specific. But there's another dynamic, which is what's the logic or the financial incentive for example, a difference in what the patients pay for Medicare and what they pay for the commercial insurance. And from a hospital perspective anyway, hospitals typically think they are able to get more of a reimbursement of costs out of Medicare or out of commercial than they are of Medicare, and more of Medicare than they are of Medicaid. So that kind of economics, the demand is a little bit stronger or less elastic in the case of commercial than Medicare. So it's not surprising from we in the United States have imbued our pharmaceutical industry with a profit motivation, and we shouldn't be surprised that they're pretty good at figuring out where they can charge more and where they can charge less. Our role here, I think, is to give some kind of transparency for what those differences are. And actually, Andrea, one thing, as we decide what particular classes or what particular drugs we should focus on, and then study and drill down more carefully, I think it would be interesting from a research perspective. My apologies, I'm a professor, I'm always looking for research topics, to keep differentiate, to get a set of the major drug classes and to get a set of drugs, specific drugs. I've here therapeutic class too. Some that we focus on as a group and provide transparencies, and some that are about the same that we choose not to focus on, and the transparency isn't improved, and see whether that makes any difference in the price. Actually happens in the real world. Just a thought, Andrew. Thank you very much. It's exciting stuff.
Sure.
Thanks. So, Andrew, just a couple maybe questions and comments. First of all, thank you. This is incredible. And the data that you showed that I don't think we have a copy of, the second slide was really breaking it down much further. I'm interested in, we have sort of a different class of drug that where it's falling in here, and those are the biologics, which are super expensive. Are they falling under dermatologics and also gastrointestinal? I'm a GI doc, so I have a little partiality to that. But those might be considered drivers under antivirals. We have stuff that's been around for a while, like Tamiflu, and then we have new ones like Paxlovid, but then we have the hepatitis C antivirals, which, are tens of thousands of dollars for a single course. Back when they were first launched, they were $1,000 a pill. So I'm wondering where those fall under all these drug therapeutic classes. Are they spread out, or are they grouped in a way that's understandable?
I'll pass that to Emily. I think, the key with this data, at least, and again, we can go back to with the therapeutic class, ultimately, we can go back to the total cost, but it, being patient cost, it may not matter too much how expensive the drug is for a table like this, because it's showing the patient cost. But Emily, that's a great question. Is there a class that kind of groups some of them together, or are they just going to flow into the kind of the conditions being treated? Do you know?
So it's an NDC to therapeutic class match. So you're not going to have multiple NDCs for drugs across multiple therapeutic classes. So however, whatever logic the drug reference supplier is using is how they'll be mapped.
But we could figure out, for instance, with some of those drugs that Sarah Sherman mentioned, that
Absolutely.
yeah, where they end up. And I have a feeling they end up in the, existing class. There's not like a really high cost, brand new biologic stuff therapeutic class. Like, we don't have that special class, but I don't think, but we'll figure that out and get back. And that kind of makes me think, oh, maybe we want to kind of pull those out of, the ones that are infrequently used but super expensive. Maybe those should be handled separately as at the kind of drug level. That might be a way to kind of get at that issue, because that's going to be, that's a different cost, complication where it's not that many people personally affected by it, but it's very costly for the purchaser, the main state, like the state of New Hampshire or Medicaid.
And Senator Sherman has a follow-up question, and after that, it'd be Senator Rosenwald.
So Paulo commented when we were talking about affordability earlier, I think Todd was talking about it. And I think we not only have the affordability for the patient, but also the affordability for the state. And that expands beyond Medicaid and actually into state plans that are covered by commercial carriers, or at least it's more in the commercial realm, I think. But so my point there would be that when we think about our charge, it really does become important to understand Medicaid and commercial, and then how it impacts the cost to the state for affordability and also the patient. So it's sort of all of the above would be my thinking of our charge. So out of that, I'm just wondering, and I don't have an answer for this, but I'm wondering if we were looking at the year-to-year increases and we had the historical changes, would it make sense for us to say, well, let's look for a threshold increase across a drug class, and if we see a threshold increase exceeding X, let's take a closer look and do that, have you and Emily do that deeper dive into as much granularity as we can get to try to understand why there was that increase. And I guess the follow-up question would be, is there a benefit to looking at a sharp decrease and understanding what are the drivers of an improved cost profile? Can we learn from that as well? So those are just, I don't expect anybody to have an answer. I think these are phenomenal charts, and they actually give me a lot more questions than I came in here with.
Senator Rosenwald.
Yeah, I mean,
Thank
that,
you.
oh, sorry, go ahead.
I mean, I guess following up, I'm mindful that our charge is the public payer cost, not the patient cost. Although obviously if we squeeze the balloon on the public payer end, somebody's gonna try and get more money out of the patient. But I'm wondering also if we were looking at not the patient cost, but the public payer cost, would we see different increased percentages? So maybe more cost is shifted away from the public payer towards the patient, which would be interesting. But also I'm wondering if we might want to think about the drugs that are more chronic use drugs, because those will have ongoing huge cost impact for the public payers, and primarily for Medicaid and for the state plans, the current employees and the retirees, whether that's possible to do. I mean, I don't even know what some of these classes are, because I don't have a clinical background, but some of them seem to me like they overlap, like the antihypertensive, aren't they related somehow to the beta blockers in terms of what they're used for? Not that that maybe matters, but I just think this is so interesting, and it's not on today's chart, but I just can't get over how much Medicaid buprenorphine is prescribed. I mean, it's just, that was in Andrew's chart the last time, and it is just huge, especially if you take out all the kids and the people in nursing homes and maybe the developmental disabilities population, and you're kind of left with Medicaid expansion. It's a huge percentage of the population that is on this one class of drugs, and that's chronic, right? Anyway, just my ramblings. Thank you, Mr. Chairman.
But
Thank you, Senator.
can I?
Yes, Andrew, please.
I mean, one, I think that's a great point that over time, right, the medical needs affect all of this too. You know, the cost is, some of these drugs are obviously, you know, is inevitable. Someone would need to take them, but you know, we still have kind of prevention out there as, you know, mentioning the antihypertensive drugs, you know, presumably some of those people didn't, you know, if they'd exercise more and eat better, they wouldn't need to take them. So you got like, and something like hepatitis C, you know, so you got kind of medical conditions driving the volume of how many people are using these drugs. So, you know, the question about buprenorphine, well, it's a bunch of people getting medication assisted treatment. And so that's, you know, kind of a flowing from the opioid epidemic. And so all of these have a story behind them of, you know, when they're a chronic disease kind of medication, you know, that ultimately is the disease is driving it, not the drug company. Or, and, you know, I think on the side around cost, some of those that just occurred to me, some of those higher cost drugs we saw as being like the top drug because they're a new drug or a biologic, you know, don't show up here as much because depending on, you know, the insurance plan, it's, you know, it may just cost me $30 a month when it's costing the insurance company $20,000 a month. So, you know, that kind of does get to, once we can isolate the state or the, you know, the state and municipal plans from commercial, you know, you can start seeing that, like, you know, what are the classes that cost the state a lot of money or Medicaid a lot of money versus, you know, the things that cost patients a lot of money. And those will be, those are going to be different stories because of the way the cost sharing works. I think for all of those, you know, Medicaid, there really isn't cost sharing to speak of. And the state employees, university employees, it's a lot of it at these fixed copay amounts. So a lot of the costs will be on the state, not on the patient, at least under the current insurance most people have. So those are all, these comments are all terrific and interesting. So, and I appreciate that the sort of the data is endless. If you think about it, it's like, it is a lot of data. And it's, so I think figuring out a strategy the board wants to take is going to be really important.
Thank you, Andrew.
Yep.
Can I ask one more
Thank you.
question?
Oh, sure, yes.
The university employees, and I probably should know this from having worked on budgets, is that something that the legislature can influence?
Oh, maybe not.
Or do we just, you know, we give them our grant and it's sort of like the judicial branch, we don't appropriate within. So they might be interested in what we could tell them, but I'm not sure that we have any levers of power.
Senator Rosenwald, that's an interesting comment. I don't know, but if the state or if the university system or other public payers which attach to the general treasury, sometimes it's self-funded. If you're self-funded, you have a lot more access to the data because it's really your data because you're carrying the financial risk with it.
Right.
I like what your thought is that we could, instead of trying to look at the, Professor Woodward said, the whole ocean and trying to find a shoreline, maybe that's where the shoreline is. If we start looking at the state plan or state employees and so
State
forth.
plan
drilling down,
and
that's really-
Medicaid
yeah.
are the
Medicaid,
ones that
Medicaid, state plan.
we really can affect.
Correct.
Thanks. Just another follow-up thought. You know, I look at the name of our board, it's the Affordability Board, and I agree that the affordability is going to be taken at the level of the patient, but also as concerning to me is the system. And what is the system the state have to absorb? So when I think about the data, and so much data as the professor mentions, it's almost, you know, too much, you know, how do you handle it? I was thinking in my mind, and I don't know if this is feasible or not, Andrew or Mary, but I was thinking about a Mendelian chart, so to speak, chronic acute versus, you know, expensive and non-expensive. So if you take that chart And we want to focus on what would be the biggest bang for our buck. It's not going to be the acute episodic care of a pneumonia that's treated with penicillin. That's cheap. It would probably be on the other side. It's the chronic, immunocompromised patient with a very expensive drug. And so right now, this chart breaks them out according to agents in their categories. Would we turn it on itself to look at those that have huge costs in a chronic bucket and break those out as a category separate from the class of drug that has a certain, diagnosis attached to it? So not necessarily something to talk about today, but just the thought that I had about how to break out and how to get at the most pertinent data, both for, patient, affordability, but also for system and state affordability. So.
Thank you. Yes, Professor.
Can I suggest a modification of that?
Sure.
Which is, I agree with it 100%. I thought about it as I was looking at the May meetings video. How about the preventive drugs? As we talked about hepatitis C, that isn't a therapy and it's not a chronic, it's a preventive. And one way to add to those two casts would be add a third, which might be preventive.
So just for clarification, the treatment of hepatitis C is preventive? Preventive of
The Soldavi,
cirrhosis? and-
it's a vaccine.
No, there's no vaccine for hepatitis C.
But I believe it is preventive.
No, it's actually curative.
No, but I'm wrong.
So, sorry, it's my specialty.
Yes.
So, I don't mean to be,
No, you've got.
but there are drugs that are preventative. And actually treating hepatitis C prevents worse disease like cirrhosis and liver cancer. So in that sense, it is preventive, but it's actually the new drugs, the new class that's been out since 2011 are pretty much,
I think this has been very, I found it useful. Andrew and Kim, thank you for again grinding some numbers for us. I think we have some additional directions to go. I would like to, if you could, in the data, start looking at public payers with this Medicaid state plan, with it's going to the University of Hampshire, because I think our charge is in that arena. I think if you want to benchmark it against the commercials that are not part of those subsets, that's probably useful. We should have some understanding we would collectively to how we're performing against the rest of the market. So the subset is the public payer, but we could also benchmark that against the other part of the universe, which is the whole commercial market. So thank you.
Thank you.
Okay, moving on to board rules. Mr. Berry and Ms. Zeno. Welcome back. I heard you had an event on your life here.
I did have.
Yes.
My life, yes.
So welcome back.
Thank you.
So good morning, everybody. Just to give you guys a quick update on the status of the rules. We've received all of our comments from the public as well as OLS at this point. So what we're doing is we're trying to incorporate most, if not all, of the comments we've received from both the public and OLS. There's substantial work that needs to be done with it. We spent a lot of time on it. Thus far, we were hoping to have a draft ready for the board today, but it just wasn't going to work out if we want to do it correctly. So we'll have it ready to go for the board to view next meeting in August. And with that, it should be able to make it to GelCar in September. I'd say.
So in order to make the September gel card, we do need to file a final proposal by August 25th.
Okay, and saying that, then can I have people look at their calendars to find out, can we find the date before August 25th, right?
That would, about a week before would be even better.
Yeah. Do we have to do it then, or can we do it later in August and file it in September? for
If you
October?
want to file in September, it would just push out the gel card to October.
Is that gonna cause us any kind of a heartburn with GelCar in their time?
Oh, absolutely not.
Okay.
Nope.
So if we look at, looking for the week of the 15th through the 19th, that's only about 2 weeks away, 3 weeks away.
of September.
of August, if we want to make the September gel car on their timeline. If we want to move it out beyond August, probably 18th, then we probably should move it down the latter part of the month. We could do like 29th or maybe sometime September. I don't-
I'm out of town. the 29th.
Okay. Any,
I could do the 22nd, I think.
22nd.
What date are we looking at?
Looking at August 22nd. Don't forget, we have to also put it in the calendars and so forth, so I have to get that constraint as well. Is August 22nd available, people?
Yeah, maybe by Zoom, but
By Zoom? Representative
I'm
Marsh?
not sure yet. I don't know what my schedule is yet, but
Yes, I've blocked the time off,
Okay. Representative Murphy?
I think so.
and I'll have my truck so I can actually come and help you make quorum.
Oh, all right.
Good.
I could do it.
Okay.
Yep.
Okay, so the 22nd of August from, is it 10 o'clock till noon? Is that still working for people?
I know we have a fiscal item on the table. And I just say that the September fiscal meeting is the 9th. So it's likely we could be on the October fiscal agenda if the rules were approved. And that is likely to be the 21st of October.
So if we, Senator Rosenwald, if we get to gel car for the September meeting, it's kind of, is it gonna make it?
The September meeting is September 15th for job car.
So if we meet on the 22nd,
We could, if there's no further changes.
Yes.
And we vote on that specific draft to move forward, absolutely.
Okay.
I can have you sign a couple of them.
Just from a political standpoint, I think it would be smart to get all this done before the election. I just, it could throw everything into turmoil if we don't get it done. So I'd recommend we keep moving and get this in front of jail car.
And I will say too, that once we file the final proposal, we will also get another round of comments to address before the actual job. So this doesn't stop just because we're filing the final proposal and being placed on that agenda. I think there'll probably be some more work to do in those 3 weeks following that.
But we won't need a follow-up approval of that additional work. Will we have to have another meeting before that?
I don't recall the last time I sat on the board and we had to do that. Normally what would happen, I believe the board had to meet after to file the conditional approval response once it was approved at JLR.
So sometime in September,
Yes.
before it goes to fiscal. There's only one approval at jail car, right? Or does it
Yes.
go back through jail car twice?
It depends on the outcome of JLR.
is it,
So it really is I kind of like to say it's a choose your own adventure book, you know, like yes, approved here, no approved, and then you have 7 more steps that you have to deal with.
so can they have what they call conditional approval?
They could, yeah, and that's what we would try to strive for once we file the final proposal
Right.
in those 3 weeks before the meeting. We have up until a week before the JLCR meeting to file a conditional approval. And hopefully the goal is to always have comments satisfied at that time. So it would make for an easy approval at the meeting.
So if we're looking at meeting on August 22nd to sign off on the final draft of the rules, that's with the intent of getting it to gel car by the 15th of September.
Yep.
The gel car at that point in time could elect to either accept them as written, or they could come back to us and say it's conditionally approved if you're willing to accept the
So
revisions?
we would know comments before the jail car meeting.
Okay,
So we would have, hopefully go into jail car saying, we know this is going to be approved,
Okay.
or we're unsure. But I always strive for the, we know this will be approved. If not, we know what issues that we want to discuss, because maybe a change, we don't want to make a change.
So just to be clear,
Yes.
this is a cumbersome process. If we get final approval on the 22nd, that's not final. We then get more comments. Should we meet again before jail cut? So that everything is tied up with a bow, or does it really matter?
I don't know either way, I guess. Because boards work a little different than if it was just me here at the department. Because normally that letter I can sign off on, I can file the changes, no problem. But here, let me look in my past board rule that I had worked on and see how we did it. It may have been that the chair had just signed off on the conditional approval request letter, and then the board came back together again after the meeting to vote on the next step, which would be the conditional approval response. And that would be after the judgment.
so if the board is willing to empower me to sign up on the conditional ones, I could do that to help speed things along.
And we could easily get a draft out there. That's very easy for us to do.
Right.
So why don't we address that?
Okay, so August 22nd, we'll still meet. We have to have the final draft done at that point in time before.
That'd be perfect, and
right.
we can file by the 25th, and I
Right.
can have the cover letter ready to go, so you can sign here.
Okay. And at that point in time, jail card is going to be on the 15th. Hopefully we could sign up with that, working with them at that point in time. If they have concerns, because you'll see it ahead of time as well.
We'll know ahead of time. Yes.
Okay. So we can go into that meeting on the 15th
Hopefully.
with the information we need and so forth. Okay.
Yes.
And once that happens, Senator Rosenwald, when is the fiscal?
So
Committee meeting.
the September meeting, I believe, is on September 9th, which is early because we're not having a regular meeting in August. But usually it's on the third Friday of a month. So I'd say the October meeting is likely to be on the 21st of
21st.
October. And then there probably is a November meeting. I'm trying to remember. But then fiscal has to get reappointed with the new legislature. So I'm not sure if there is a December meeting. So it'd be good to take this off the table in October if we can, so that we could move towards hiring, because we could accept the fee.
Correct.
And also to just, the October Delta meeting, in the event you do need to go that far, is that Thursday, the 20th. So it is the day before fiscal. Normally it's the same day, but it's the day before.
Sorry, what is?
Yeah. I was gonna say. The jail car meeting in October, Senator Rosenwald, is on the 20th, one day before fiscal.
Oh, okay.
So we got two shots at it.
But
I
that's
guess.
fine, because
Yeah.
you wouldn't need to submit a new item. We have it on the table.
Correct. So we're gonna meet on August 22nd. Do we have to come back in September for anything at this point in time, or are you looking at a date in September?
I would say if you're trying to get this off the table for the fiscal meeting in October, maybe towards the end of September.
Because if there's concerns that they have to come back to the board to address, then we can address them to get it back to jail car on the 20th to finalize it, and then hopefully get it to fiscal on the 21st.
Mhm.
So
Why
looking
don't we
at
say the 26th?
26th. Is that gonna work for you, Senator Rosenwald?
What day?
It's September 26th is Rosh Hashanah.
Yep.
Okay. About the other books, September 26th from 10 till noon. That's not the Monday. Best Woodward?
Yes.
Yep.
think so.
On the way.
Go away. Okay. All right then, so we have a date set for the next couple of meetings, August 22nd, September 26th. Awesome, thank you for that, Mr. Barrett.
Less than that.
All right, the other one that's on the agenda is on the executive director. That was changed in the statute, so now we have to go to GCEC or some of that.
Yeah, so I'm
not sure
working,
exactly which.
I'm working with our internal HR process, all those documents ready to go. But the first step, it'll go to administrative services. From there, it'll go to the Corn Ferry Group, which they go through the process of evaluating our suggestion for the labor grade and things like that. And then they will put forth the recommendation to JCEC. JCEC will ratify the suggestion from the Hay Group or not. My understanding is most of the time I do ratify it. Then it'll go back to the Administrative Services Commissioner, and then we can post it.
Can I just have a collective moment of exuberance that our
Yes.
bill actually made it to the legislature? Yay, Representative Representative Murphy, great job. Senator Rosenwald, yay.
I have a question for Mr. Barry, if I could.
Sure.
Would it be possible to use an authorized and funded but vacant position and we change the title of it? Would that save any time?
I can certainly ask about that. I know with the unclassified positions, it is a little bit easier to move them around to fit current needs within the department, which is why sometimes people have official titles that don't actually match what they do anymore because of the way it works. But I'll check with HR to see if we have any unclassified positions that are currently vacant and not being used for anything, to see if we can use that and if it speeds up the process. And then I think from there, then I think the next step would be to change the title in the statute for the corresponding position.
So the statute says it's unclassified. Why would it have to go through the Corn Ferry process? Isn't that for classified?
Well, this is what HR is telling me. I can follow up again to make sure that it's the same process.
Okay,
I think they were pretty clear that that's the process it goes through, but I'll follow up again and get some clarification on that. I don't know if it's because it's a new position and it doesn't have a pay grade associated with it. Potentially, that could be the holdup.
okay,
but I
there's
don't know.
one third possibility, and that's non-classified. And we did that this year for the Hampstead Hospital purchase. Fiscal is able to approve, accept money and approve for non-classified positions. So if we could just figure out what the fastest way to do this is.
So yeah, this is a non-classified position. So, and you
It's
raised
non-classified or unclassified?
classified and, well, isn't non-classified, unclassified the same?
No, they're different.
No, they're not?
They're different. I just learned this after
Oh, well, that's
18
news.
years.
Well, that's news to me and I've been doing this 9 years. Then no, this is unclassified if we're using the.
So
specific-
there's a possibility of non-classified too, which is kind of more short term, but then you can change things. So
Okay.
I guess my question is, could you please try to figure out at DAS what the fastest way to do this?
Okay. I'll find the
Thank you.
Ferrari of position establishment.
Thank you.
No. All right. Thank you for that as well. That does bring me up to one of the things that the RSA that is now law, we do have a non-lapsing account, and Senator Rosenwald, this is probably to yourself along with Representative Murphy. If we do have now non-lapsing account for the board, can we begin to send out an invoice, because the statute's clear about what the floor is. There's no ceiling to it, but we know there's a floor, the minimum amount that can be assessed to those who are going to be assessed. Could we, at this point in time, send out an invoice? I'm trying to get to is working on the fiscal year, state fiscal year from July 1 through June 30th. And this would nicely tie into that. And then at that point in time, we do have a list of entities that have registered with the board. So we could, in a sense, send out an invoice for the assessment fees.
I guess I would defer to Mr. Berry on whether we need the approved rules first.
So I've sent out an email to our finance group here citing this SB 450, asking if there was any way that would expedite the process for accepting funds. And I haven't quite heard back yet. To be fair, I only sent it to him this morning. So I wasn't expecting a response yet, but I will let you know as soon as I get that response, what that is.
Mr. Chairman,
Yes.
would it be possible to make one brief comment?
During public comments.
Public comments.
No
Yes.
public comment?
No, during the public comments.
That may be too late. Can we move public comment up on the agenda?
Not until we get to the presentation.
Well, you might want to check the statute. in the interim.
So in regards to, you're going to follow up with them, figure out what we can do. All right. And moving on to the other one, I think we have Mr. Wagner on the Matt on the Zoom for a presentation about the community pharmacy and the role they play in the pharmacy supply chain. It's the last, I believe, the entity, if you will, from the manufacturer to the patient, the community pharmacy. So welcome, by the way, to the board. Thank you.
Thank you. And yeah, thank you for the opportunity to present. Go ahead and share my screen. Just want to make sure that my screen is visible.
Yes, it is. You may want to resize it.
Okay.
You've got the first and the second slide showing.
Yeah, you have your notes and so forth. It's
Oh, the notes, yeah. Let's see.
Whose presentation mode for, yeah.
Yeah.
Sounds like somebody's done these PowerPoint
Somewhere.
How about now? Is that better?
Yes.
Fantastic. Great. Well, thank you again for giving me the opportunity to talk to you today. So yeah, as mentioned, my name is Matthew Magner. I'm with the National Community Pharmacists Association. I am the Director of State Government Affairs. And I wanted to go over community pharmacies' role in addressing drug prices and what we can do to help patients. So just to give you a little bit of background on who NCPA represents and what makes us different from other members of the pharmacy community. So we are the community-based healthcare professionals and entrepreneurs. We are independent pharmacists, and that makes us uniquely positioned to customize solutions to healthcare challenges affecting local communities and employers. So we like working with the patients, and we believe that some of our solutions can actually help not just the patients, but some of the plan sponsors and the the people paying for the prescription drug benefits. So just a little bit of more background information on the community pharmacists. There are 19,400 community pharmacies nationwide, 18 of which are in New Hampshire. They are local employers and they contribute to the tax base. They provide civic leadership. We like to point out that community pharmacies are often the folks sponsoring the Little League teams and providing other services, not just for their patients, but for the community at large. And 80% of community pharmacies are located in areas with a population of less than 50,000. So they are in essential healthcare providers, typically in underserved areas, in either the rural areas of states and many urban communities also that don't have other healthcare providers nearby. They are frequently the only healthcare provider in a community. And community pharmacists are the most accessible healthcare providers. One study has found that patients visit community pharmacists almost twice as often as physicians or other healthcare providers. So any solutions that are to patients, healthcare issues, whether it's finding the right medicine or finding the right cost, a pharmacist is going to be an integral part to that solution. So here are some of the drug cost concerns that pharmacists see for their patients. One is formulary issues. Insurers or their PBMs create formularies to determine which drugs are going to be covered. And so because of that formulary, it'll determine whether there's going to be a brand drug will be covered or whether an equivalent generic will be covered. And it's not always the case that it's the generic is covered. Frequently there is a brand version of a drug that a pharmacy will have to dispense in order for the drug to be covered under a patient's plan. Even if that brand drug is not necessarily the cheapest option for the patient. These formulary decisions can be made for a variety of reasons, including rebates with the drug manufacturers. They provide rebates to the insurer PBM to get onto the formulary. And the question then becomes, is the patient going to benefit from that rebate? Which may not always be the case. Another issue are narrow networks limiting access to community pharmacies. It's not uncommon that a patient simply cannot go to their local community pharmacy. They have to use a pharmacy dictated by their plan. And in that case, the pharmacy, the community pharmacy, simply cannot help the patient, has no access or ability to work with the patient. And this can be a cost issue if the patient is forced to go to a pharmacy that is actually more expensive, which is not uncommon. A lot of times patients have to go to a mail order pharmacy instead of having the choice to go to a retail pharmacy. I'd point out one study found that retail pharmacies provide lower generic drug costs than do mail order pharmacies and higher rates of generic substitution. So it could be the case that a patient, if the patient went to a retail pharmacy, they could find more options and work with a pharmacist to find the most cost-effective option. But narrow networks can completely keep a retail pharmacy out of the equation if a patient simply doesn't have the choice to go to that community pharmacy. Another issue are differences in reimbursements, particularly with affiliated versus non-affiliated pharmacies. It's now very common for PBMs or insurers to own their own pharmacies. And there are differences in the way those affiliated pharmacies are reimbursed from non-affiliated pharmacies. It is sometimes the case that those affiliated pharmacies are actually reimbursed at higher rates than non-affiliated pharmacies. For example, Florida Medicaid in an audit found that their managed care organizations and the PBMs that owned pharmacies, those pharmacies were actually reimbursed at higher rates than non-affiliated pharmacies for specialty drugs. This is when coupled with the previous point of the narrow networks and having patients steered to a particular pharmacy. This means that a patient sometimes is steered to a pharmacy that costs more. And again, they just simply don't have the ability to work with a community pharmacy to address some of the cost issues. And then it also not only impacts the patient paying out of pocket at the pharmacy counter, but then also the plan sponsor and the whole plan as a whole when these affiliated pharmacies are charging more for the same drugs. Something else that pharmacists see are price concessions, rebates, and retroactive clawbacks. It's not uncommon for when a pharmacy dispenses a drug, they will be reimbursed at the sort of get their initial reimbursement at the point of sale. But then later, some of that reimbursement may be clawed back either through some form of adjudication fee or some form of effective rate reconciliation. So essentially the initial reimbursement is not the final reimbursement. But when a patient pays out of pocket at the counter and their what they pay out of pocket, if say they're in the deductible phase and their payment is tied to the initial reimbursement amount, when that is subsequently lowered, they don't necessarily get the benefit of that lower reimbursement. In other words, their out-of-pocket costs are based on an inflated amount. Same with the manufacturer rebates. So as I mentioned, the formulary issues are often dictated by manufacturer rebates. So a patient may have to use a more specific brand name drug rather than a generic drug because of the rebate. But the question is, does the patient at the counter get the benefit of the rebate from the brand drug? And so what can be done? What have states done, and what can pharmacists do to alleviate some of these issues? For the formulary issues, we just want to ensure that pharmacists have the authority to work with patients and prescribers to find more affordable alternatives, even if it's paying cash. I know one issue that are the gag clauses that have been dealt with by most states and at the federal level. And so that is a great way to help alleviate some of the issues that again lets the pharmacist, it keeps the pharmacist from being contractually prohibited from telling a patient that there's a cheaper alternative, even if the cheaper alternative is not using your healthcare plan and just paying cash for this drug. But a similar, what else needs to be done is protecting patient choice, because again, a pharmacist cannot offer that type of advice if the patient is not allowed to go see that pharmacist. So there are a lot of states are looking into addressing patient choice issues. For example, there are 28 states that have any willing pharmacy provisions. That's where the insurer and their PBM create the terms and conditions for network participation. But any pharmacy that's willing and able to meet those terms and conditions for network participation will be allowed into a pharmacy network. And then there's a more, some states address it more specifically with anti-mandatory mail order provisions. So this would those provisions prohibit an insurer or a PBM from requiring that a patient use a mail order pharmacy in order to have their drugs covered. So they can have, each patient will have the ability to choose a retail pharmacy where they can have a face-to-face interaction with a pharmacist. And so there are some varying levels of these types of laws. Some, for example, some of the any willing pharmacy states say that a PBM or insurer has to contract with any pharmacy that's willing and able to meet its terms and conditions. But it doesn't necessarily address some of the, say, preferred network issues where they'll allow the pharmacy in one network, but not all networks. And so even though they might be an in-network pharmacy, there might be some issues in which a patient still can't get to that in-network pharmacy because they're not perhaps in the preferred status. Or they might have a form of penalty, such as a higher copay or some other fee to see a retail pharmacy as opposed to the mail order pharmacy or another pharmacy of the PBM and insurer's choice. And so those, again, are issues that states have started to address, and really that just allows the pharmacist to become the community pharmacist, the retail pharmacist, to have the opportunity to be a part of a patient's healthcare team and to work with them to find the right drug for them. Other states have, about 12 states have addressed the reimbursements to affiliated pharmacies that I mentioned. So a lot of times those laws simply state that a PBM or insurer cannot pay their own pharmacies more than they pay a non-affiliated pharmacy, that there has to be some parity there with those reimbursements. Some states just say they need to be more transparent about those reimbursements, let the plan sponsor know when they do have an interest in a pharmacy that's in the network, and let them know about the differences in reimbursements. And so that's those are more laws that can just give plan sponsors and patients a greater idea of how their healthcare dollars are being spent, and how their pharmacy choices can impact the overall costs for the plan. Continuing that, states have also looked into increasing pharmacy reimbursement transparency. As I mentioned, some states have required reports to plan sponsors. So the PBM serving the plan sponsor has to give information to the plan sponsor about the pharmacies that they own, the reimbursements that they give to those pharmacies. They also have to be more transparent about the number of rebates they get from manufacturers and what happens to those rebates. Are they being passed on to the plan sponsor? Are they being kept by the PBM? Or what else is being done with them? Other issues are that can be included in these transparency reports are the retroactive clawbacks from the pharmacies. So that way they're not just transparent about the initial reimbursement, but also anything else that flows from the pharmacy back to the PBM, and which would address the next issue is spread pricing, which you may be familiar with, but that's where the PBM reimburses a pharmacy one price and then charges a plan sponsor a higher price for administering that claim, and that difference is called the spread. So some states, a couple states have actually outlawed it for all payers in the state, saying, spread pricing is just not allowed. Others require more transparency, saying, well, if you're going to engage in spread pricing, you have to be upfront about it with the plan sponsor and let them know how much they are paying in spread pricing. And I think one issue we see with these laws is they typically seem to apply just to the initial reimbursement and don't necessarily cover the retroactive price concessions that we see with pharmacies. Another issue that states are moving to is removing those retroactive reimbursement adjustments. I know New Hampshire has a law in the books about retroactively reducing a reimbursement amount. And so New Hampshire is not alone in that. There are states that are prohibiting the retroactive clawbacks, the adjudication fees that artificially inflate costs for patients, particularly those in the deductible phase. And then there's one, a big retroactive reimbursement that we see is in the Medicare Part D program. They're called DIR fees, the direct and indirect remuneration. And that is, as mentioned, a pharmacy is reimbursed one amount and for filling a Part D prescription, and then a DIR fee is charged months later. And so that initial reimbursement is actually lower than it initially appears. And so starting in 2024, Part D will move all the DIR fees up front to the point of sale. And this is going to benefit patients because now their cost share, what they pay at the pharmacy counter, is not based on the inflated initial amount. It's based on the amount that takes into account the DIR fees. So the patients will no longer be paying based on an inflated amount, but on the actual reimbursement amount. And that's going to save patients over $26 billion in the first 8 years that it's implemented. That's according to CMS, the Centers for Medicare and Medicaid Services, their estimates. It'll save patients over $26 billion in the first 8 years. Another issue that states have been looking into are the rebate pass-through. Making sure that manufacturer rebates are going to the patients who are paying for the brand drug that's getting onto the formulary. So West Virginia recently passed a law last year that would require 100% of the manufacturer rebate to be passed through to the patient at the pharmacy counter. That way, if a patient is forced to take a brand drug because of a rebate, they at least get the cost benefit from that decision. And something else is expanding the pharmacist's role. This is something that can help lower costs overall. As I mentioned, pharmacists are the most accessible healthcare provider in many communities. People see their community pharmacists more frequently than other healthcare providers. And so this is a great opportunity for patients to have more services done at the pharmacy counter. There are two obstacles to pharmacists providing more services. One is the authority to practice at the top of their license. So there are a lot of things that pharmacists have the education and training to do, but they don't necessarily have the legal authority to do so. And some popular ones that states have recently been expanding, of course, immunizations. And then there's also hormonal contraception, there's smoking cessation drugs, and there's HIV, PEP and PrEP drugs. Those are 4 things that states have really been looking into and expanding, allowing pharmacists the opportunity to prescribe these drugs and administer these drugs directly to patients. So the other obstacle is not just having the authority, but having a means of reimbursement. It's common when a state expands the pharmacist's role and allows them to provide these new services, the pharmacists still can't really provide the service because they just don't have the means of getting reimbursed. It's something that they would have to not only do for free, but it would cost them the actual time and resources it takes to provide these services. And so just making sure that there is a way that a pharmacist can, that this can actually be something that they not only have the authority to do, but that they can actually afford to do to provide to their patients. And those are just ways, again, to address some of the rising costs by allowing the the pharmacists more opportunities to provide more services to their patients. This has a great benefit to patients and to payers. There are increased vaccination rates when pharmacists have the ability to provide vaccines to their patients. And it also for the payers, it's also seen as it can increase the promotion of a value-based care, which is a more efficient way of paying for services when pharmacists have the ability to provide more services. And so those are just some of the ways that pharmacists can get more involved in the efforts to lower drug costs for patients, and what we've seen from some of the states that have successfully done that. And so I'm happy to take any questions. But yeah, thank you again for giving me the opportunity.
Senator, thank you for that presentation, by the way. Senator Sherman?
Thank you, Mr. Magner. I'm wondering, what is the typical rationale for, I guess, two things. One is the clawbacks, and the other is the DIR fees. I would think that would really be tough for pharmacists or pharmacies if they think they are getting X for a drug. They've gone through the whatever it's called, the encounter with the patient at the counter. Everything is settled, and then later on, they're told, oh, by the way, your reimbursement for this is actually, you have to give us money back.
Mm-hmm.
How do they justify that?
So for the DIR fees, it's my understanding that it began as a sort of quality measures. And so it was a way to reward or penalize pharmacies for meeting or not meeting various quality measures. But I think as the issue is we saw it move away from that. And I don't have the actual numbers on me, but I can get them for you. I believe over the past about 10 years, DIR fees, the pharmacy price concessions increased by 45,000%, an astronomical amount, which clearly indicated that we had moved away from this an issue of quality measures, because that you would have to ask yourself, has the quality of pharmacy decreased by 45,000% to justify an increase in DIR fees of 45,000? And so so you're right, it makes it very difficult, if not impossible, for a pharmacy to sort of know how to carry on with their business if they don't know what they're going to be paid or what they're going to be charged months down the road, which is why they changed to the Part D rule that's going to become effective in 2024 is overall a good change, because it's not only going to help the patients because they're going to be paying less at the pharmacy counter, but it will give pharmacies a greater idea of what their actual reimbursements will be. And there will still be a role for the quality measures. It's not going to be so controlled by the PBMs serving the Part D plan. And similar in commercial plans, we can see the same issues. And then we also see what's called generic effective rates, where at in the contract, the PBM will say, we're going to reimburse all generics at a certain effective rate based on the wholesale acquisition cost. So it might be, WAC minus, I don't know, I'm making up numbers, minus 80% or so. But then when when a prescription is filled at the pharmacy counter, they the PBM may not actually reimburse at that effective rate. They would reimburse at some other rate. And then months later, they would do what's called the reconciliation, the true up, and determine whether they overpaid or underpaid based on the effective rate, and give the and then reconcile the difference. And again, that just creates less transparency, and we're not, pharmacists have a difficult time knowing when they're reimbursed at one rate, whether it's going to be clawed back months later, or whether there's going to be another change. But those are sort of the how they came into being, the quality measures or the effective rates. But we're seeing they really sort of have moved away from their initial intentions.
Thank you, Mr. Chairman.
Yeah, so just follow up on clawbacks. Is that the effective rates, or are there other justifications for clawbacks?
So clawbacks can come in other forms, such as adjudication fees. So if there's just having the claim adjudicated, there can be another fee, a fee that the pharmacy has to pay to the PBM. If there's an issue with that reimbursement, if they say want to appeal to the PBM, and say, I think there was a mistake, there can be, again, more fees just for the transaction of having the PBM look at the payments. There can be more supposed quality measures, even in the commercial space. And I'm sure there are more, and I'm happy to look in to see if, I don't know if there's a nice handy list that has all the types of clawbacks that pharmacies can see, but I'm happy to gather such a list.
So just last, I guess it's almost more of a comment, but maybe you can respond, not to sound cynical, but it doesn't sound like there's anything stopping a PBM from saying, you know what, we're not making as much profit right now as we should be, so we're going to hit pharmacies across this state with retroactive reimbursement adjustments and meet our targets, and then being able to justify that through clawbacks and adjudication fees. I don't see how a pharmacy can do business when they don't know what their bottom line is going to be down the road. It sounds like a roll of the dice.
Yes, and that is an issue for a lot of our members. The lack of transparency really makes it hard to run their business. And we've seen pharmacies close because they simply can't, deal with the lack of transparency and some of these under reimbursements. And it has, it does have a real impact on pharmacies, particularly in the rural and urban areas that would otherwise be pharmacy deserts without the community pharmacy that's there. So if one community pharmacy closes, an area that was served by that pharmacy may now be become a pharmacy desert. And so, yeah, we've definitely seen, the adverse impacts on community health when a community pharmacy closes.
Thank you. Representative Murphy, then also on to, after Representative Murphy, Senator Rosenwald.
Great. Thank you, Mr. Chairman. And Mr. Magner, thank you very much for this presentation. I guess my question is more one of comment and question, and it has to do with the overall structural transparency of the entire pharmaceutical industry, but also on that of the PBMs. And when I was in a hospital, we were dealing with PBMs a lot. I was never at that time aware of the fact that they owned many of the pharmacies that they were dealing with, or that they controlled the rebates. And I guess my question is really, it's the structural part that's so confusing to me, as we've come and talked about this so many times recently, is about the steering of patients, the narrowness of networks, the affiliated versus non-affiliated, and do they get paid more than their non-affiliated ones? And to me, that just keeps speaking to me about the lack of transparency, not only of the PBMs, but the industry in itself. And I guess my question to you is, in your opinion, where does the real lack of transparency reside, or is it spread throughout? Is it the manufacturers? Is it the hospitals? Is it the retail places? I mean, we who have been in medicine for a long time really felt we had a grip on a lot of this. And I can tell you right now, after listening to so much of this, is that I have less of an understanding and grip than I did when I was actually directly dealing with so many of these people. So I guess my question is more of a philosophical, but just a general, as we try to tackle affordability, where is the greatest transparency in this entire pharmaceutical industry coming from? That you may not be able to answer that, I get it, but I get frustrated, but also concerned about the fact that we are punching in the dark at something that I really don't understand that well.
Mhm. Yeah, thank you for that. I think at least from the pharmacist perspective, what we, what our members see are the issues, what's really impacting the pharmacy-patient relationship. That's really what we see, and we do see the interference coming from the PBMs, and we think as you mentioned, a lot of what's causing it are a lot of the conflicts of interest. So when a PBM is reimbursing a pharmacy, and also reimbursing themselves when they own a pharmacy, there's definitely an incentive to create those reimbursements that benefit the PBM. And when they are creating networks and telling patients where to go, there's always the incentive to help the PBM. And so I think, we at NCPA like to point that out and have addressed that conflict of interest. And I think from the larger perspective of where all the transparency is, I'm sure there's, every player, could benefit from more transparency. So I can really just speak to what the pharmacies see. And that's what's impacting their relationship with the patient.
Thank you. Senator Rosenwald?
Yes, thank you, and thank Mr. Magner for this interesting presentation. I was under the impression that New Hampshire, a few years ago, we changed our laws to prevent the clawbacks. Am I right? Or did that bill finally not make it over the finish line?
So it's my, and for this presentation, I looked at your New Hampshire statutes, and it looks like the law is on the books as long as it hasn't been sunsetted, but I don't think it has.
I don't think there's a sunset. So
Okay.
that, to me, it looks like one we've already done.
Yeah, and so I think the big question is, it's not just having a law on the books, but then also making sure the law is enforced, and that the law is broad enough to encompass, all of the types of retroactive clawbacks we would see. Make sure it's broad enough to include all of the plans, whether they're commercial plans, whether they're ERISA plans, whether they are state-run plans or other publicly funded plans, and also making sure that it's not just broad enough to include everything, but specific enough to then have some real teeth behind it.
But we can't affect ERISA law,
So,
can we?
So there, in 2020, the Supreme Court issued a ruling called Rutledge versus PCMA that addressed they looked at an Arkansas law that would have regulated PBMs that serve ERISA plans. And the Supreme Court determined that the Arkansas had the authority to regulate to apply its laws to PBMs that serve ERISA plans. And so there is ERISA is not at least a complete bar to state enforcement of laws against ERISA plans, particularly PBM laws. And the Arkansas laws dealt with reimbursement issues between the PBM and the pharmacy. And so I believe that the New Hampshire law that addresses the retroactive clawbacks would fit nicely into the type of law that the Supreme Court was interpreting in Arkansas. And so I believe that under the Rutledge ruling, New Hampshire would have the authority to regulate ERISA plans, and it's definitely something that the state should look into if they're not currently regulating ERISA plans.
Thank you.
Yeah, thank you very much. Interesting presentation indeed. I'm coming at this as a newbie to this board, and excuse me if I'm asking overly simple questions. What percent of the New Hampshire scripts are covered by your members?
That's a good question. I do not know. I do not know the percentage off the top of my head. That's something I can see if we can get some information on. But as I mentioned, I know there are, based on 2020 data, that's what our most recent numbers are. There are 18 independent community pharmacies in New Hampshire, and I have somewhere, I can give you an idea of how many other types of retail pharmacies there are in New Hampshire. I'm happy to follow up. But yeah, I'm not sure based what the percentage is off the top of my head. So that's something I'm going to have to follow up with you on.
Follow-up question would be, what percentage of the areas under 50,000 would be covered by your members also?
So that is, so in New Hampshire, getting a map of the pharmacies, that's something that I might be able to do. Again, that's not something I have currently. I don't have a map of all the independents in New Hampshire, but that is something I believe that I can help with.
Your presentation focused on the importance of your independent pharmacies to rural areas. One of the sort of sub issues on any New Hampshire issue is the coverage and the impact on any policy on rural areas, of which there are quite a few in New Hampshire. And my last question is, what's the variation reimbursement in New Hampshire for vaccinations? One of the issues you talked about was the value of increased vaccination rates in by New Hampshire or by independent pharmacies. Are vaccinations not covered in New Hampshire in general?
So, so for vaccinations, I'll have to look into what New Hampshire public programs like Medicaid to see, but I don't know what the state is on the commercial state is. I don't know whether commercial plans are offering reimbursements for vaccinations, but I can talk to our members to get an idea of those vaccine rates. And I want to circle back to your previous question about the number of pharmacies in rural areas, and I wanted to bring up something that we are looking into nationwide, because you bring up a very excellent point of the number, when there are pharmacy closures or openings, you know, and determining whether there are more overall pharmacies in the country or fewer, one thing that we sort of ignore or don't look into is where the pharmacies are opening, where are they closing, and where are the pharmacies opening. And so if you know, a lot of pharmacies are closing in rural or the underserved urban areas, and a lot are opening in suburban areas that are very well served by the number of pharmacies that are currently there, we may not see the actual impact of the pharmacy closures if you just look at raw numbers. And so we are actually working with a team to address that issue and see are the, you know, is the number of pharmacies, is the total number of pharmacies in the country, is that really indicative of the number of pharmacy deserts there are? So we're essentially working on a project to identify pharmacy deserts in the country. And so I can get more information about where the local community pharmacies are in New Hampshire, but I did just want to point out that that is something we're working on, addressing the issues of pharmacy deserts. Because again, if you say, you know, in any given state, you know, we had 10 pharmacies open last year, that may not address the fact that, you know, 30 pharmacies opened in already well-served areas, while 20 closed in areas that now make it those areas of pharmacy desert. So I did just want to bring that up.
Thank you, Ms. Magnet. Also, Attorney Fay.
Thank you, Mr. Chair. Mr. Magner, thank you again for your presentation. I have a few, and we're going late on time, so if you can just maybe just brief sort of yes or no responses to these questions. Of the 19,400 pharmacies nationwide, how many do you count as members? Roughly, if you can say. If that's proprietary, you don't have to.
Yeah, I don't know the answer to that question. I honestly don't know the answer to that question.
And the trend lines for independent pharmacies, up, down, flat?
We've seen a decrease in the number of independent pharmacies nationwide over the past 10 years or so.
And my last question, thank you. Representative Murphy asked a question about transparency, and I don't know that you fully answered that question, because I thought it was very telling, and you did spend almost a half a page on what lack of transparency is, how it's affecting your members. So if you could supplement that answer, maybe look at the tape, I would be grateful to hear your thinking on it, because obviously you do see this from a different angle than others do. Not that you were not being direct, but it was a kind of a complex question with multiple parts. But it seems like you would have answers to those questions, or maybe upon digging, you would have more that could be informative for us.
Sure. Yeah, I'm happy to supplement. Absolutely.
Thank you.
Thank you.
And I want to say thank you for your time this morning and helping us understand the role of pharmacy. The community pharmacies would be woven in the pharmacy supply chain. It's an incredible important one. In regards to moving on to the assessment fees, we talked about some public comments. I think this is probably the appropriate time, Mr. Bunstein, if you wanted to chime in on your public comment.
Actually, I'm fine.
You're fine?
Nothing useful to add.
Okay. Is there any other public comments from the public? Anyone? Oh, yes.
Sorry, I just had one question for the speaker, and I don't know if he's still on or not, but he was discussing that for folks who have payments at the counter that are co-insurance, so not like a flat co-payment, but a co-insurance that based on the reimbursement that the pharmacy will ultimately get, and that he was describing that over time, you know, months or so later, that reimbursement gets reimbursed, but the co-pay was still, the co-insurance was still pegged off of that higher reimbursement. My question is kind of a two-part. One, does he have an estimate of for his members about, because I assume that overpayment, if you will, is being held by the pharmacies, the payment that's made to the pharmacy. So my question is, does he have an estimate of what that overpayment is? And secondly, I was interested about in the discussion about transparency, what sort of transparency tools, I guess, either in place or potential for pharmacies? Because there was a lot of discussion about PBM transparency, but I was just wondering if the pharmacists and the pharmacies are doing anything around it. Not to necessarily be answered now if he doesn't have the answers, but those are good questions.
Did you hear the questions, Mr. Magner?
Yes, so
If you could do me a time-wise, sensitive to the time, but if you could respond to that in a written statement, something would be very helpful for the board to understand.
absolutely.
Unless you can wrap it up and do it relatively quickly.
No, I can, so I think that I understand the questions as, had questions about how much about the overpayments of the co-insurance for patients, how much, do we have numbers about how much that is? And then transparency measures for, I think, pharmacies specifically.
Exactly. So
Okay. Yeah, I'm
So
happy
what-
to.
what is the pharmacy community itself doing to provide greater transparency on its own self? If we're asking for transparency from the other entities within the pharmacy supply chain, what is the pharmacy world doing to provide transparency on its own?
Great. And I'm happy, yeah, for time wise, I'm happy to follow up on those.
Thank you. And no other public comments. We don't have a need to go into a non-public meeting with the AG's office. So at this point in time, I'll remind people we have agreed to meet on August 22nd from 10 until noon, with a follow-up meeting on September 26th, which is also a Monday from 10 to noon. Our goal is to get the gel car for the September meeting. Is that correct? And hopefully onto fiscal for the October meeting. And they're going to follow up as far as if we can possibly at this point in time invoice an assessment fee, because the statute is very clear about what the floor is. We can't go above that without getting to the rulemaking and so forth, but we could possibly still go with the floor.
Yes.
Based upon some statute. Okay. And also the DEC with
JCEC.
okay. Joint Committee on Employee Compensation. I learned that acronym. So is there any other comments before we
Question, do we have on the agenda a report from Andrew with the database on one of those next two meetings?
I'm going to circle back with him and find out what he has for time to get back to us. If you're willing, given the background with economics and data and so forth, I would welcome a Zoom meeting with he, yourself, and myself and talk about, what we can do and how to slice and dice it. I think what I heard, I want to be clear, is to focus more of our attention on the public payers, which is Medicaid, state plans, and so forth. But really, that's kind of our goal. We can benchmark against the commercial, but really our focus back into the size of the ocean here is what boil it down to a smaller universe. Right.
At your pleasure, I would do that.
Thank you. Is that motion to adjourn? So moved. Anyone want to debate that? Thank you.
Thank you.
Thank you all. This is good numbers.
Heidi.
Right.
Yeah, pretty good area.
No, those were good.